Good morning, everybody, and I'm very excited to welcome you to day 2 of IVI's 4th Annual Methods Summit. I am Jason Spangler, the CEO of IVI, and I'm just excited again to welcome you all. For those of you who were here yesterday, I hope you enjoyed a great day 1. Yesterday we talked about what it means to say there's no value without equity. We heard about economic burdens of health conditions as being a key factor in addressing health equity. And we were just so honored to have so many great speakers, starting with Dr. Dora Hughes, the Chief Medical Officer of CMMI, where she talked about CMS and CMMI's work around equity and applying it to the value work and the modeling that they're doing. And so that was a great start to the day. Then we had a great session with Donald Cryer from the Global Liver Institute, and her mantra, no value, no equity, is something that you will hear again and again from the work that we're doing. We had some great panels talking about the recommendations from our synthesis report that came out last week regarding everything that we've learned around our health equity initiative. And the first panel talked about the recommendations that we put forth, and then we had 2 panels after lunch talking about what can HTA producers do and those who use HTA as well. And so, a great way to finish the afternoon was with Dr. Nikhila Cook, who is the executive director of the PCORI, the Patient-Centered Outcomes Research Institute, which was a great segue into day 3. So just a couple additional thoughts that you're going to hear again and again that we had heard yesterday. Again, when it comes to health equity and value assessment, we have to start with the patient, and you're going to hear about that since today is focusing on the economic impacts to patients and their families. The people that have lived experience in the healthcare system, so patients, caregivers, their families, they speak a different language than value assessors, and we heard that yesterday as well, and that different than researchers also, and that we need to bridge that divide and speak the same language as those do as well. We also heard that value assessment, as well as just all of those who do healthcare research, can't just account for the average patient. There's incredibly important considerations for people outside the average, and those who, like us, deal with HTA have to account for that. And then, just as Dr. Nikhila Cook finished with yesterday in our last session, economic impacts of disease on patients and caregivers are very significant, and they're often missed and can exacerbate health disparities. So there's definitely a relationship between the health equity work and the economic impacts work that we do. And that's why we had this method summit as a 2-day session with both of those incorporating into the summit itself. So again, just pleased to welcome you to day 2. We're going to focus today on how we can consider that full range of economic impacts on patients and caregivers when we evaluate healthcare. We're very happy as IVI to be working in partnership with Academy Health on this year-long project to kind of develop a framework for researchers and decision makers in healthcare that will help guide in incorporating, again, the full range of economic impacts for people with those lived experiences in their conditions. We want to really thank not just Nikhila Cook, Dr. Cook, for being a speaker yesterday, but also just PCORI for their support for this project. We have an engagement award with them, and we're just grateful for that support and that leadership. And we hope to continue that into the future. We also just want to thank our sponsors for the overall Method Summit. Pharma, Alexion, and Janssen have been generous in their support for our 2-day summit. And so we just wanted to thank them. And finally, just thanking all of our members. Most of our revenue as a nonprofit organization comes from our membership dues, and they support all of our research and convening activities. And lastly, I want to thank you as the audience just for participating, whether just today or yesterday and today in our Method Summit. So as we move into the final stage of this economic impacts project, and in the spirit of kind of a learning laboratory, which is what IVI is all about, we just want to share with you today, and this day 2 of the summit, the learning so far around this framework and just the taxonomy that we're trying to generate with this work. And so with that, I'm going to turn it over to Jennifer Bright, IVI's Chief Strategy and Engagement Officer, and she's going to start our first session. Jen?
Thanks, Jason, and good morning, everybody. As Jason said, I'm Jennifer Bright. I'm the Chief Strategy and Engagement Officer for IVI. been with the organization for 5 years, and these are some of our favorite programs to host. I'm really privileged today to welcome on camera two women have been with us on many journeys over the last several years, but both Gwen, Darien, and Gretchen Wartman have been part of the steering committee for this economic impacts work that we've been doing for the last several months. So Gwen and Gretchen, please feel free to come on camera with me. Great, good to see you. So we're gonna just have a half an hour of chit-chatting about why are we talking about this issue? Why have we been working to collaborate to take on this pretty big challenge of defining economic impacts and thinking about how they're measured? So maybe starting with Gretchen, maybe you could just introduce yourself a little more fully and share with the audience why you think this initiative has been such an important conversation.
Thank you, Jennifer, and good morning, everyone. I'd like to thank IVI for continuing to include the National Minority Quality Forum in these conversations, but I very specifically want to thank Jennifer. I met Jennifer maybe 4 years ago, and the commitment she made during our conversation was that she was going to open conversations to the full range of perspectives and give them voice. And she has done so in a way that it made it clear to me that she is a person, a woman of her word, and that's extraordinarily important as we move forward with these conversations. As a result, we had an incredibly robust and open conversation yesterday, and which forced me to rewrite my unscripted remarks at least 3 times during that session. Because what we heard was that we all recognize that there is a challenge and that the system, the actors in the system who have agency to make change must engage. And one of the, I would say, what should impel them forward is a recognition that equity does not only affect certain population cohorts. It affects all of us, either in the moment or in a future, not too distant future, research delivery and financing system that affects us all, particularly if it's compromised by lack of data that enable more precise responses to the health challenges for which we are all at risk. And if we are lucky, will enable us or have a system that will enable us to seek treatment that is effective. So I don't know, for those of us who are unfamiliar with our organization, the National Minority Quality Forum is a 501c3 not-for-profit research and advocacy organization that's based in Washington, D.C. Our capabilities include federal and state policy analysis and advocacy, issue-specific alliance development, community-based provider quality improvement initiatives, and data collection and analytics. Our mission is to reduce patient risk by assuring optimal care for all. And our vision is an American health services research delivery and financing system whose operating principle is to reduce patient risk for amenable morbidity and mortality while improving quality of life. So I'll stop there as my introduction. I don't think I gave my title, which is Vice President for Policy and Program of the National Minority Quality Forum and Director of our Institute for Equity in Health Policy and Practice. Thank you.
Thanks, Gretchen. Gwen, what are your thoughts and your work at the National Patient Advocate Foundation and why this project is so important to you?
So thank you. And thank you. It's a great pleasure to be on the screen with Gretchen and Jennifer. And I wish we were in person, but here we are on the screen. So my name is Gwen Darien, and I come to this issue from multiple perspectives, but the two main perspectives are as a 3-time cancer survivor. I was diagnosed with cancer as a young adult, and I've been doing patient advocacy for almost 30 years at this point. And so the lived experience I had in being diagnosed with cancer 3 times, the economic impacts were really quite, the economic and other kind of burden impacts were really something that I, as well as my cohort of fellow cancer survivors, a lot of us who are young adults, really faced. And we'll talk about that a little bit later. But it wasn't just financial cost, but it was also opportunity cost. It was cost of what happened to us personally in terms of our ability to have families, our ability to do certain things that many other people in our cohort did not have. And like many people, I came into advocacy to help ensure that people who came after me did not have the same experiences that I did, and help, and also to find community. I think people often don't acknowledge that advocacy is also community, and a way of community really impacting and change through community. And then the National Patient Advocate Foundation and the Patient Advocate Foundation are devoted to equitable access to quality, affordable healthcare for everyone. We focus on serious and chronic illnesses. And at PAF, it's our direct patient services. We help patients access through financial and social needs navigation, the care that they need and that they deserve. So we start from the perspective that everybody deserves equitable, affordable, and quality care, and everything that we do is based on that principle. And equity is the underpinning principle of all that we do. At the National Patient Advocate Foundation, we take what we learn from the patients that we serve at PAF and develop projects that work on changing the system and work on changing the healthcare delivery system. We focus primarily on healthcare delivery. So the kind of overall learning circle of these two organizations is that you can't change the system unless you understand what is happening to individuals, and you can't help individuals unless you can change the system. So that's what we really focus on. And primarily people come to the organization because they were having financial barriers or burdens to accessing healthcare. So this is a critical conversation for the patients we serve, the patients we work with, and the cohort of cancer survivors to which I belong.
Gwen, I love the way you put the symbiosis between the individual and the system, and how it's cycle, and they have to live in harmony in order for us to be making good decisions. I love that visual image. The project itself we undertook with the support of PCORI, not only for our interest in how do we improve the definition of inputs that are being used in economic analysis, but because it was such a huge strategic imperative for PCORI itself in trying to understand economic impacts. So could you just share briefly, each one of you, we've worked, and we will hear in a moment more detail about how we've worked to define the edges, if you will, of what we mean by economic impacts. But from where you sit, what's the impact, even short-term impact, of improving our definition and how we measure economic impacts? So give an example in your mind of how this is going to materially improve our measurement of economic impacts.
So I think one of I was reading the findings from the roundtable that you did, and I see that there are a few people on the screen who are part of that roundtable. And one of the things I love that somebody said was that all of the cost and all of the economic burden comes from one wallet for the patient. And we often, in the way that we approach this, in the way we as a larger healthcare community approach this, we divvy these parts out. We talk about clinical impact, the cost of clinical care. We don't necessarily talk about health. I think about things as health. We don't talk about opportunity costs. We don't talk about the cost to the family, the cost to the community. So I think that's one of the most powerful images as we think about this, is that it all, from the perspective of the patient, it all comes from one wallet.
Yeah, I think, Jennifer, and I think there were 3 questions in there. I was trying to determine which one of them
I'm known for that, sorry.
I was going to answer. But I would say that and where the National Minority Quality Forum is that mitigation of risk for the patient has to be central. Not the only thing, but central. The system in which we within which we all must engage tends to be motivated by mitigation of financial risk. And so I would say yes to Gwen, it's all one wallet, but that wallet is divvied up. It has different points of access. And those whose business models, and almost by definition, because it's a business model, focus on mitigating financial risk, need to be, we need to take steps to incentivize them to see it differently. And that's the potential of the economic impacts initiative in which we're engaging. But I would, when you link equity to that, I think a challenge becomes that we have a health services research, delivery, and financing system that was forged in a society that accepted inequity legally and socially. And the policies, the business models, the blindness to the impact on other populations, whether directly or indirectly, was encouraged. They were able to balance their books by creating structural inequity. And part of what we're seeing with, I would say, the value assessment / health technology assessment models that are in our environment walk through that enter through that financially mitigating financial risk window. And so I guess, as a result of, or as a pull through from the work we're doing on the economic burden conversation, and sort of following up, Jennifer, on the recommendation that we all recognize where we are and do what we can where we are, is to also open our minds to different value assessment and health technology assessment processes that are occurring throughout research, delivery, and finance. Yes, ICER is there, but ICER is not the only value assessment process. It's got a big footprint, but at the state level, at the federal level, in the commercial and the public sector, technology assessment, value assessment through the financial mitigation lens is occurring every day, and we must recognize it and take action where we can. And so I'm going to speak briefly to the data. The need for data was mentioned constantly yesterday. It's been an issue since I started working, which was 50 years ago, I think. It continues to be an issue, and it will continue to be an issue because our ability to be more precise in the type of data we collect evolves as our skills evolve. So in my lifetime, my work lifetime, we've gone from recognizing the need to just count everyone
Yeah.
to finding ways to acknowledge the existence of all the population cohorts, to then taking steps to make sure they're represented in the work we do. But what we're now challenged to do is to ensure that all the work we do throughout this, once again, compound complex systems loop reflects the needs and is able to be responsive to the needs of all populations. The Economic Impacts Project is a way of doing that because it speaks to a language that our business environment speaks, which is money. And so I will turn it back to you, Jen.
Gretchen, that was really well put and actually led really nicely into my next question, which is, where are there factors, environmental factors or changes that are happening that create a more fertile ground for this conversation or the use of this kind of framework? And you just framed one of them, that the business community is talking in a different way. We, through this project, are starting to get our hands and mouths around the type of talking in terms that resonate with that community. So that's one example. But Gwen, any thoughts about other steps or factors that can influence the use of this framework going forward?
So I think there are a couple of things I was thinking about. I was listening to Gretchen and thinking about some of the things that she said, and to build on some of the things that she said. I mean, first of all, a lot of these things, we have these conversations where a lot of things are implicit, and we have to be very explicit, and we have to be really bold, and we have to be really direct. And we aren't always bold and direct. We often are, we just assume everybody has the same values as us. We assume everybody has the same perspective as us. But I think one of the things Gretchen said really early on was the kind of rising tides of focusing on equity. And one of the things that you do, if you center equity, you raise everybody's experience and everybody's equitable access. So one of my friends who works in the space likes to say that equity equals excellence, and it does, and it equals excellence for everyone. It's not just excellence. It rises everybody's boat up. And there's a initiative at the NCI for workforce diversity, which is really, the NIH for that, which is really, really important. The other thing that's really important, as I was listening to Gretchen, is that it's not just about counting everybody, but it's ensuring that when we count everybody, there is a standard of how we count and how we account for people's, how we account for demographically, how we account globally. I mean, there's just, it isn't just simply about making sure that everybody's counted, but it's making sure that there is some kind of standardization about the way that we count people. And then I think finally, of course, from a patient advocate and patient perspective, making sure that the patient is in the center is something that is really critically important, and why it's so important that PCORI is supporting this work. And if you are centering the patient, you can't center the patient unless you understand what the burdens that fall on the patient. And, I've been in these conversations for 15 years, more years around value and the conversations about patient-centeredness and putting the patient in the center. And I often say that I feel like Flat Stanley. I don't know if everybody remembers that, where there was the cutout piece of paper that people would, I did it for my nephew, where you would put Flat Stanley in every place in the center and you'd take pictures of him. And I often felt like Flat Gwen in these value conversations, where I was stuck in the middle, but I wasn't looked at in 3 dimensions as representing patients. I was looked at in this 2-dimensional cartoon cutout. So I think it's really critical that as this project is developing and as this initiative is developing, that patient-centeredness is not just jargon, it's not just a check the box, and that it really truly is integrated, valued, and and lived. It's a lived value, not just a stated value. And I think that's one of the things that we're talking about is going from kind of the stated values to embedding and embodying these values.
That beautifully put. And I do not want to see flat Gwen or flat Gretchen at all. I mean, I think you bring so much passion, and I feel it through the Zoom lens, believe me, and I'm sure our audience does too. You know, thinking about next steps, and I wish we had all day to have this conversation, but sadly we're at kind of a final question for each of you, which is, if you want our audience to take one action following this conversation to advance this conversation about economic impacts and the work that we've been doing, what would that action be?
I don't know if it's one, it's maybe three, but I'll be quick. One is for the health economists, for the value assessors to remember that which we know, which is that they are all patients as well, current or potential. Two, that all individuals have social determinants of health. Some constrain access, some increase or facilitate access, and that you bring your lived experience to your jobs, to your work, as value assessors or health economists. Whether you're conscious of it or not, I would say do that work to make sure that you too can influence equity where you are, because it's you. And I would say as a third, which is a plug for the Institute, is to join with us in our Centering Equity initiative. This year, last year we launched the initiative, and as part of that, we launched a survey that spoke in a very precise way to different types of inequities and the intersectionality, or potentially the intersectionality of those inequities. And just 2 weeks ago, we launched the 2023 version of that survey. We plan to continue doing it every year as long as we can be here. And I will, before the end of today, share in the chat a link to the survey and ask all those here who are, as we defined yesterday, aware to take the survey and share it with other thought leaders or those who have the ability to influence this conversation.
Wonderful. Gwen, last word.
So I think that we're all here because we're all passionate about this, passionate about economic equity. We're passionate about equitable healthcare. But one of the things that we don't do often, and as I said, I've been in these conversations for a very long time, is really pull back the lens into some historical context. And Gretchen referenced that in terms of what the financial context and the context of people accessing healthcare. And I've always been a little shocked when I come across people who don't have any idea of the history of redlining and what that's done to health and access to healthcare. And then, so I think it's really, really important to tell the truth about our history as the framing for where we start. And a panelist in a workshop that I facilitated really said, let's just tell the truth. So I think one of them is to really look at what our context is, look at how we got to this point of economic, of looking at economic impacts and ensuring that there's equity across that. And then I think the other issue is that we talk a lot about how words matter. And I just mentioned this to Jennifer and Jason when we were waiting to come on camera. I was at a meeting the other day, and they still were using Michael Porter's definition of value, which is an economic definition of value. It is not it's not a person-centered definition of value. And the only way to change any of this is by actually creating and adopting a person-centered definition of value. And that we all use regularly, often, and out loud.
I love that. And it kind of speaks to my call to action yesterday, to those that were with us yesterday, that we all, I challenge everybody on the phone to be a bit of an evangelist and carry forward what both of you have said, which is, words matter. We need to have context, and we need to remember that the patient and the family are at the center of this, and not just in a token way, but in a very real way. I can say that the Economic Impacts project that I've been working on with Erica and our team is so meaningful to us, because I think it gives heft and detail and explicitness, to use your word, Gwen, to this concept of economic impact, which I believe too often has been, summarized down to only meaning out-of-pocket costs or point of sale cost sharing, which we know and we have learned from all of the folks that have been with us on this journey is the tip of the iceberg. And so I think that, leaving our audience with the notion of this is a more explicit conversation about economic impacts that we're having today and forward, and for all of you to learn more about this and carry this narrative forward with your inspiration from our two panelists this morning. Gwen and Gretchen, thank you so much.